Buenos días, good morning everyone, buen día a todas y todos. Les doy la más cordial bienvenida a este evento de la Organización Panamericana de la
I
Salud.
cordially greet you to this event organized by PAHO.
Quisiera informarles que
I'd
tenemos
like to
traducción
tell you all that we
simultánea
have
a tres
simultaneous
idiomas,
interpretation
español,
into three
inglés y
languages,
portugués.
Spanish,
Ustedes pueden
English, and
elegir el
Portuguese.
idioma de su preferencia
So you
utilizando el
may
icono
choose
del
the one
globo
of
que
your
está en la
preference. It's on the
parte
icon of
inferior
the
de sus
globe
pantallas. And for this webinar,
below.
we will have simultaneous translation in English, Spanish, and Portuguese. And at the bottom of your screen, you will see a globe. And if you click on the interpretation globe, you can select the language of your choice. Mi nombre es Pedro Abedillo, soy asesor regional de
I'm Pedro
tuberculosis en la
Abedillo, the
Organización
regional
Panamericana de
consultant
la
for
Salud y voy a
tuberculosis from
introducir
PAHO,
este
and I will
webinar.
be
Saben
introducing
que
this
estamos en
webinar.
un momento muy
As you
importante
know,
para
we're
la
in a very
respuesta a la
important moment
tuberculosis.
for our response to
Afortunadamente, en los
tuberculosis.
últimos años estamos viendo
Fortunately, for the
muchos
last
avances
years, we have
tecnológicos,
seen a lot of
innovaciones que nos
technological
permiten mejorar de forma
progress and
sustancial el abordaje de
innovations
la
that allow
tuberculosis
us to
y
address
afortunadamente contamos con avances
substantially the
tecnológicos
issue
que
of
pueden
tuberculosis. And we
cambiar
have
la forma en la
technological
que diagnosticamos
advancements to
la
help us
tuberculosis, ¿no? Y
diagnose
ampliar el
tuberculosis and
diagnóstico, que es
also
una
to
de las
expand the
principales
diagnosis, which
brechas que
is one of
tenemos,
the most important
conseguir
gaps that
llegar
we have
antes a las
found,
personas,
to be able to get
iniciar
to people
antes el tratamiento y reducir
and to
así la
start the
carga que
treatment
supone
on
esta
time,
enfermedad
thus
para
reducing the
las
burden
personas que la
this
padecen, para
disease
sus familias y
brings to
acelerar
those that
el
suffer
paso
the disease and
hacia la
for
eliminación.
their relatives and
Saben
going toward
que en
its
realidad
full
tenemos una brecha
elimination.
muy
As you
importante
know, we
en el
still have a very
diagnóstico, casi
important gap
80.000
in the
personas en la
diagnosis with
región que no
almost
están
80,000
siendo
people in the region that are
diagnosticadas
not
cada
being
año y
diagnosed
que
every
las que se
year, and
diagnostican
that those that are
todavía lo
being
realizan de
diagnosed
forma muy tardía, ¿no? Con
are still
enfermedad muy
being
avanzada,
still
con más
receiving their
riesgo de
diagnosis quite
secuelas,
late with
de
a very
desenlaces
advanced
adversos y con una
disease
mayor
and a lot
transmisión de
of
la enfermedad
sequels and
en la
effects and a
comunidad. Saben que
further
todavía
possibility
dependemos
of transmission within
demasiado
the
de
community. You know, we
técnicas
still
obsoletas
depend
como
a
la
lot
vaciloscopía
from
para el
obsolete
diagnóstico de
techniques
inicio
as
de la enfermedad,
bacilloscopy
que la
for the
capacidad de
diagnostic,
diagnóstico de las
that the
pruebas moleculares
capacity for the
todavía está
molecular
muy
testing
centralizada en muchos
diagnosis is still
países y que por
very
tanto esa
centralized in
cobertura
many
de
countries.
pruebas
Therefore,
rápidas
the coverage
moleculares
of quick
para
molecular
el
testing
diagnóstico
for the
de la enfermedad sigue
diagnosis of
siendo
the
muy
disease
limitada en
is still
muchos
quite limited
contextos, ¿no?
in
Y van
many
a ver a lo
different
largo de este webinar y
contexts.
de los
You
siguientes
will see
webinars que
throughout
vamos a
these
tener
webinar and the
sobre
next
las
webinars that we'll
novedades de
have
diagnóstico,
about the
que las nuevas
diagnostic
recomendaciones
for
que
many
tenemos de
diseases.
OMS
What are
nos
the
van
new
a permitir
recommendations we have from the
ampliar con estas
WHO
nuevas tecnologías,
that would
ampliar y
help us
acelerar el paso
expand these
para
new
cerrar
technologies
esas
and
brechas.
cover
Y desde
further these
ya
gaps?
quisiéramos hacer un
So
llamado
from now on,
a
we'd
los
like
países
to
para que de verdad
make a
podamos
call to the
acelerar la
countries so that we
implementación de estas
can
novedades que tenemos. Hay
implement
algo que
better
sabemos muy bien, que
about this
tardamos
disease.
demasiado
We know
entre
very
que
well
tenemos
that
la
it took us too
recomendación
long
y
from
las
the
tenemos
moment we have a
implementadas y ampliamente
recommendation toward
implementadas
its
en el terreno, ¿no? Tenemos
implementation in
un
situ.
retraso
We
importante y
are
tenemos
showing
que
an
empezar
important
a
delay, and
implementar
we
cuanto
need to
antes y
start
reducir esos
implementing
tiempos para
as
que
soon as
todos puedan
possible to
beneficiarse
reduce those
de las
timelines so
novedades.
that
Por eso
everybody
tenemos esta
can
serie de
benefit
webinars
from this. That's why we
regionales,
have these
que el objetivo es
series of
poder
regional webinars with the purpose
comentar o
of being
presentar,
able to talk
discutir
about,
las novedades que tenemos
discuss
en
about the
diagnóstico y el día de
novelties we
hoy
have in the
vamos a
diagnosis.
presentar una revisión
And
general
today,
de las
we're going to
recomendaciones
show a
de
general
OMS que
review
va a
of
presentar
the
el
WHO's
doctor Ernesto Montoro
recommendations
y
introduced
también
by
vamos a hacer
Dr.
un enfoque más
Ernesto del Toro.
específico
And
de
we're
una
going
de
to
las
make a more
innovaciones
specific
que nos
approach
traen
to some of the
las guías, que es
innovations
el
brought by the
agrupamiento o
guides,
el pool
which
de
is the
muestras
clustering or the
de
pool
spute, que sabemos que tiene un
of
enorme potencial
sputus
para
samples
mejorar la
that have
eficiencia
a
y
great
optimizar
potential to improve
recursos.
efficiency
Para todo esto
and harness
contamos con
resources.
un grupo de
In order to
excelentes
do that, we
ponentes.
have
Nos
gathered a
acompaña
very
la doctora Patricia
interesting
Hall,
group of
que es
speakers. We
la
have
team
Dr.
lead,
Patricia
la
Hall, the
líder de
team
equipo
leader
de
in the
testeo y
testing
diagnóstico del
group and
Departamento de
diagnostic
OMS
group
de
from the
tuberculosis, de VIH,
WHO Department
hepatitis
of
e
TB,
ITS en Ginebra, que nos va a
HIV,
dar
and
su
hepatitis,
perspectiva
and Geneva,
global sobre
who's going
estas
to give us
recomendaciones.
her
Y
global
también
perspective in these
contamos, nos
recommendations.
acompañan
And
y
we also
agradecer
have
desde
with
ya
us, and we
socios
want to thank
clave
you from now
que
on to
junto con
all
la
of you.
OMS han
We
hecho
have key
posible que
partners
tengamos
that
estas
together with the
recomendaciones
WHO have
hoy.
made it
Queremos
possible
agradecer
to have these
especialmente a los
recommendations
colegas
today, most
de Unitaid que
specifically
nos
our
acompañan, a
colleagues from
Marianne
Unitaid,
Touré,
Mariam
por su rol
Touré,
fundamental
for her
financiando la
paramount role
evidencia que
in the
permite que hoy podamos
funding
estar
of the
presentando esto a
evidence
través
that
del proyecto
allows
Star
for
for
us to
All
show
y
these
un
through the Staff for
agradecimiento
All
a
project.
los equipos del
Much
proyecto Star for All,
gratitude
a Tom
to all
Winfield,
the team
Ana
of Staff
Isabel
for All,
Cubas
Tom
Atienza
Wilfield,
y a Víctor
Elizabeth
Santana
Cues-Atienza,
Santos, que
and
van a
Victor
compartir
Santos,
sus
who are going to be
experiencias
sharing
concretas, los
their
resultados
specific
de las
experiences and the
investigaciones que
results
están creando
of
y que,
all
como les
the
decía, han
investigations
creado
and
la
research that
evidencia
they
que
have
hace
conducted. They
posible
have
tener
put together
estas
the
nuevas
evidence to
recomendaciones.
allow having these new recommendations
Recordad,
put together.
tenemos habilitado la sección de
We
preguntas y
have enabled the
respuestas, de question
Q&A
and answers, por si quieren poner
section
sus
if you
preguntas que
want to
estaremos
ask
contestando a
anything
lo
that
largo del webinar.
throughout the
Y
meeting
yo
we
sin
will be
más me
able to
gustaría dar
be
la palabra
answering.
a Patricia
And so
Hall,
without further ado,
agradecerle de
I'd
verdad
like
por
to
estar
hand it
aquí
over
hoy
to
con
Patricia
nosotros y
Hall to thank
felicitar a
her
ella
for being here
al
with
equipo
us
de Ginebra de
and
OMS
also to enable
por las
the
guías.
team of
Patricia,
the
te
WHO in
paso
Geneva
la
for
palabra. Adelante,
guidelines. So
gracias.
Patricia, go ahead.
Gracias, Pedro. Buenos días, bon dia. Good day, everyone. I'm sending well wishes from Geneva at WHO headquarters and very pleased to be joining this great team today to speak and help open this webinar. I think those of you attending today will be familiar that we have a global goal of ensuring that all individuals who need access to tuberculosis diagnosis testing have access to those services, that they are able to be initially tested with molecular and WHO recommended rapid diagnostics. However, we know that we still have gaps in achieving that global goal of universal access. According to our most recent WHO global report, in 2024, only 54% of individuals globally were tested with a WHO recommended rapid diagnostic. And this remains true across many regions of the world. In the Americas region, this also remains true, where in 2024, 48% of individuals with presumptive tuberculosis were initially tested with these tests. And Pedro has rightly highlighted here today that there have been great advances in technology and approaches and in strategies to help us try to address some of these gaps, particularly as programs are facing real financial constraints for health service delivery and for procurement of a lot of different solutions that are needed for tuberculosis and for other diseases. And so that's why we were so pleased over the past year to work on this new TB diagnostic policy and to release the new recommendations for near point of care molecular TB tests for the first time that can be used in peripheral settings, expanding access where services may not otherwise have reached, that complement existing testing technologies and investments that have been made by programs. Also, tongue swabs that allow testing of individuals that cannot produce sputum, allowing those individuals to now have access to bacteriological confirmation of disease, many for the first time. And our focus topic for today as well, for a new diagnostic strategy of pooling that Ernesto rightly mentioned, where many sputum are pooled together, allowing for programs to efficiently optimize the use of their resources and also with the potential to achieve faster turnaround times for patients and more optimally utilize the investments that they have in their networks today. And so we would not be able to go through this guideline process if we did not have sufficient investments and high quality evidence coming our way from a variety of multi-country settings that allow us to really use data and evidence to drive these new recommendations. And I'm very pleased to be joined here with PAHO colleagues by our Unitaid colleagues, as well as colleagues from Start for All and from the Brazilian program, many of whom were involved in generating the evidence that helped to underlie the recommendations. Sometimes programs see the recommendations, but they don't always see the information that underlie and lead to the recommendation. And so very pleased to be here today to say that. And also, I want to thank Unitaid and Start for All for continuing to support now the implementation of those recommendations by releasing some very practical tools and materials that I'm sure will be spoken to today as well. So with that, very much looking forward to the event. We are here for any of your questions and comments throughout the day. Thank you to PAHO colleagues for the invitation and for arranging this. And back to you, Pedro and colleagues.
Thank you so much, Patricia, for your words, and thank you so much for joining today. Continuamos
Thank
con,
you, Patricia, for your words and for being with us today.
continuamos con la agenda.
We now
Vamos a
continue
dar
with
paso
our
al
agenda,
doctor Ernesto
and we're
Montoro,
going
que
to
saben que es
continue with
asesor
Dr.
de
Ernesto
integración de
Montoro, who is the
laboratorios en la
consultant of
Oficina
the
Regional de
integration
la
of labs
OPS.
in the regional
El doctor
office
Montoro va a
for
presentar
PAHO.
las
Dr.
nuevas
Montoro will
recomendaciones de
introduce the new
OMS sobre el
recommendations from the
diagnóstico
WHO
de la
on the
tuberculosis. Adelante, Ernesto,
diagnosis
por
of
favor.
tuberculosis. Go ahead, Ernesto.
Gracias, Pedro. ¿Se me escucha?
No me aparece en pantalla completamente.
Yo lo tengo.
Selecciona share cuando tengas compartir, selecciona el
Sí,
más.
sí.
Sí, se
Está bien, se
escucha.
escucha bien.
Ven acá a ver. No se ve. Pantalla completa.
A mí me sale no.
Ven acá a ver cómo. ¿Se puede ver en pantalla completa? ¿La ven?
Todavía no.
Ujú.
Mira, a ver, tú acá. Vamos a ver. Sí. Es que yo no sé con eso porque me salió. Creo que selecciona. Ahí está bien. No, espérate, ese era el PowerPoint.
¿Cuál es?
Es que tenía esta.
No, pero esa no está entera. Es esta.
Vamos a pasar a ver. Es que puede ser esa imagen. Esta es mi imagen. Bueno, disculpen la interrupción, ¿no? Bueno, ya como se anunció
Again,
tanto por
apologies for the
Pedro como por
interruption.
Patricia,
As Pedro had said,
vamos
and
a
Patrice as well,
mencionar cuáles han sido
we
las
are going to
nuevas
talk about the
recomendaciones que
new
ha publicado
recommendations
el
published
pasado mes de febrero
in the last month of
la OMS
February
en unas
by
comunicaciones
WHO
rápidas, ¿no?
in
Sobre las
some
nuevas
quick
recomendaciones relacionadas con el
communications
diagnóstico
and
que
the
han
new
sido muy
recommendations that have to do with the
bienvenidas
diagnosis that
por parte
have been
nuestra y de
quite
los países
welcome
por el
from
avance que
ours and
representa
the
que ya
countries
se
because
mencionó
of the
la brecha
advance
que
that
todavía existe
that
en el
means.
diagnóstico
The gap has
y
been
todavía la
mentioned in
baja
the
cobertura que
diagnosis
tienen
that
las
still
pruebas rápidas
exists on the
moleculares en
low
la región.
coverage molecular
Estamos
quick testing
aproximadamente en
have
un
in the region.
50%
We're
de la
about in a
utilización
50% of
del
the
diagnóstico de las pruebas rápidas
utilization of
moleculares
the
como
diagnosis
diagnóstico de
of
inicio
quick
para
molecular
casos menos
tests as
recaídos
initial
y realmente
diagnostic.
debemos aumentar esta
And we
cobertura
still have
basados
to
en las
increase
metas
this
que se han
coverage based
trazado
on the
la estrategia fin de la
objectives
TB,
that
que es
we
alcanzar
have
el
put together for
100% de
the
pruebas rápidas
full strategy,
moleculares
which is to reach the
para el
100% coverage
2026.
of
Es
quick molecular
importante para
testing for
transformar el
2027.
diagnóstico,
It
¿no?
is
Con
important then
miras a
to
acelerar la
transform this
eliminación de la
diagnosis,
tuberculosis,
looking to
que a pesar de que existen en la
eliminate
actualidad mejores
tuberculosis,
tecnologías,
that
los sistemas de laboratorio
although better
siguen siendo un
technologies
cuello de botella
exist,
que
then the
retrasan el
lab
diagnóstico y no van a
results are
reducir el
still a
impacto en
bottleneck
la
that delay the
eliminación.
diagnosis and will reduce
Contamos en estos
an
momentos
impact
con
on the
sistemas de
elimination.
laboratorio
Right now,
centralizados,
we have centralized
lentos
lab
y poco
systems that are
centrados en la
slow
atención de las
and that are
personas
not as
y es
focused
necesario
on
o si
people
no
care.
transformar las
And it
redes
is
del
necessary
diagnóstico,
to
no avanzaremos
transform the
hacia la
diagnosis
eliminación.
networks, because
En la
without that,
figura
we
que se
will
muestra
not
en la
advance
parte
into
derecha,
the
vemos que
elimination.
sí, que con
On
estas
the
nuevas
right, we can see
recomendaciones,
that these new
muchos de estos
recommendations,
aspectos han
much
sido
of that
cubiertos o
has been covered or
pueden ser sustituidos, como es el caso de la
replaced
vaciloscopía con
as the
pruebas rápidas moleculares,
bacilloscopy with
la
quick molecular
descentralización con las
testing,
pruebas
the
cercanas al
decentralization
punto de atención de las
with
personas.
POC
No
NATS
solamente
testing.
existen
And right now,
plataformas para una sola
we
enfermedad, sino que las
find not
plataformas
only platforms for
multienfermedad
one disease,
que han
but
sido
multi-disease
recomendadas desde
platforms
hace
that
varios
have
años
been recommended for several years. We're not only then working with the diagnosis on sputum testing, but also in non-breathing testing as well. And so what we're looking to do with these recommendations is for them to, is that the diagnosis is closer to the person that needs that assistance. And also coverage needs to be improved so that these tests can do better and to cover the population with timely diagnosis and to try for the manufacturers, the diagnostic methods are not as expensive than those that existed before. Here we can see the timeline of the different guidelines from the WHO published in recent years. On the latest years, we find that there is a lot of guides, operative manuals and guidelines, but all of them had a final purpose to be able to increase the coverage of quick molecular. For the needed, what skills must the lab staff have, as well as the infrastructure requirements needed for those labs. We can see that we have technologies based on types and the point of care, which are the techniques of chromatography, immunochromatography, lateral immunochromatography for in urine, a quick test that it's available to use by the patient's pillow in minutes, and it goes together with the diagnosis of tuberculosis for those that live with HIV. The new class that is incorporated for the first time are the NPOC and ATs. And we're going to see what are those technologies recommended. We already knew about prior publications on the amplifications of low complexity nucleic acid testing, and also the low complexity in the manual ones, the moderate complexity ones, LPAS, LPAS, and the NGSs. So we know that now in this new technology, we're going to have the incorporation of the antigens in the point of care, which is a lateral flow for the detection of antigen that helps us with the detection of tuberculosis, incorporating as new the MPOC and AATs that we mentioned before, and the technologies for the included products that are recommended, which is the MTBs, TrueNAT, and now we have the amplification class, the LC-NAATs, where we update the use of the group for the grouping of sputum and the clustering of swabs. We also have for SPRI-TB and MDR-TB, the MTB RIF, and the recommendation of including M2NAD from BlueBio for the including of the swabs as well. We keep with the classification of the manual LC NAATS. We have not had any different recommendation. Years ago, we'd only have the tuberculosis complex inclusion, keeping only the types of amplification of moderate complexity, where we would include the BDMAX, the MDR, MTB, and QB-type, both for the detection of tuberculosis as the one for resistance for rifampicin and influenza. Summarizing, or what we will now talk about in the new recommendations, we say again, the amplification tests, the MPOC NATs, with the tongue swab, recommended for the methodologies of low complexity, like GeneXpert and TrueNAT, and the recommendation of clusters put them for the LCA NATs, in this case, recommended for GeneXpert. we find that the new technologies of MPOC are different from the amplification testing of LCA NATs that we mentioned before in regards to the complexity in the use of reactants and the availability of robust equipment. It is not needed to have the precise use of pipettes. We don't need a specialized molecular biology staff, and something else is about this setting and the use of these technologies of MPOCs that could be decentralized and can be taken to the point where people need care to that primary care level. It can be used in active search, used in mobiles. So this can be completely decentralized to the most peripheral areas. In this picture, we find how the requirements of technologies and mini-DOP that needs of a prior device or equipment that we will describe for the license of the testing. For the nucleic acid testing, you put it in the mini-doc, and in less than 25 minutes, you already have results and response. Here's a recommended test, both for sputum and swab as well, tongue swabbing, where the lysis procedure is using the plus light thermolyze, which is causing a chemical, thermal, and mechanical disruption to be able to cause lysis in mycobacterium of tuberculosis and release nucleic acids. This is basically the amplification assisted by RAM, where all the elements of LAMP and RNASA with the enzymatic excision are working for the signaling of the probe, and it includes internal controls included in a card that we're going to talk about later on. Very summarized, we find a procedure, a very simple technique, as you'll see, the collection of the sputum, also with the tongue swab, the picking up of the test directly for 30 seconds. It's a recollection that is a specific in the requirement of the 30 seconds, and you make the mixture in the tube that comes with the kit. You need to mix for 10 movements. Then the first step in the pre-treatment and the thermolyze and the plus live thermolyze device equipment, when there's going to be a heating up process on the vortex for 5 minutes to 70 centigrades from 3000 RPMs, and then it's placed on the card where the reaction is going to occur, and then the result is obtained in a period that ranges between 5 to 25 minutes. The considerations in regard to the swab, they can be gathered by healthcare staff or self collection. If it's done by healthcare staff, it needs to be done in a well-ventilated space using PPEs, the goggles, the face, the N95 face masks, gloves, and a robe. It is recommended that the flock nylon swabs are used, and the duration of what I said before and the tongue swabbing is important because the sensitivity is lower when the swabbing is done for less than 30 seconds. I want to show you some of the features of the Plus Life, where it can be operated with electric power, also with share or separate batteries. It is necessary to provide a preventive annual maintenance. A storage for the kit which needs to be done to up to 40 centigrades, and the storage of the equipment can go from minus 20 to minus 55 centigrades. So far, the shelf life of these cars that show the testing is 13 months. And the results are, as I said, obtained in much less than 50 minutes. You may ask, what is the cost of the test for every card? And it's $3.60 for each test kit card. And if it's, as you can see, it's an important saving of over 50% of the cost of what's being merchandised in the cartridges of Aspect Ultra. Thermalize cost is $180, and the mini dock costs $155. So to purchase both
el diagnóstico
equipment
es
and to achieve
aproximadamente
that
de
diagnosis, it's going to be about
$335. Como les
$335.
mencionaba, cada
As I
prueba tiene un
said,
control
each
interno
test
que
has
incluye la
internal
prueba y
control
además se
included in the
comercializan
test,
o se disponen
and
de controles
also
externos
you
positivos
have
con precios
positive
muy
external
económicos.
controls as well
También
in a
es
very
recomendable y
inexpensive
poder mencionar
price.
que estas no
It is
son
important to
plataformas
mention that these
multienfermedad,
are a
multidisease, es decir, que no
multi-disease
solamente
test platform, so
se
it's not
pueden
only
utilizar para el
used
diagnóstico de
for the
tuberculosis,
diagnosis
sino
of
para
tuberculosis,
sarcoidosis,
but also for
monkeypox,
SARS-CoV-2,
influenza,
monkeypox,
enfermedades
influenza,
ITS, además de
ITS
otras que están en
disease,
desarrollo.
and so many others that are undergoing in
La
development.
recomendación que hace la OMS es que se
A
utilicen
recommendation from the WHO is
los puntos
that
de atención cercanos al paciente
the
en adultos y
point of
adolescentes
care that
con
is used
signos y
as
síntomas de
MPOC
tuberculosis
in adults
que
and
se pueden
teenagers
utilizar
that
en el
have
sputo,
signs and
debería
symptoms of
utilizarse como prueba de
tuberculosis
diagnóstico
to be used in
inicial
sputum
para la
that should be
tuberculosis
used as
en
initial
sustitución de los
diagnosis
métodos
test
convencionales
and
como es la
replacing
baciloscopía.
the usual
Además, cuando
bacilloscopy
no
or
se
traditional
puede
methods.
obtener esputo,
And when
se deberían
sputum cannot
utilizar
be
estas
collected, then
tecnologías en hisopos
this
innovados
technology should be
como
used
pruebas
in
diagnósticas
tongue
iniciales,
swabs as
igualmente que
initial
la anterior
diagnostic tests,
recomendación.
just in the prior
Hacemos algunas
recommendation.
observaciones, que es la
We made a set
evidencia
of
que se dispone en la
remarks and
actualidad,
observations.
o estas
It is being
recomendaciones están
said that right
basadas
now these
para esputo expectorado
recommendations are
inducido,
based for
y el esputo sigue
expectorating
siendo la muestra
sputum
preferida por
or
una mayor
induced,
sensibilidad
and
y
that's
debe
still
recogerse y
the preferred
utilizarse siempre que
testing
sea
way.
posible,
And it needs to
dado
be
una mayor
collected
precisión
as much
diagnóstica,
as
como lo
possible
habíamos
because it
mostrado
has a lot more
posteriormente con relación
precision
a
in
la
terms of
sensibilidad y
diagnosis.
especificidad en comparación con los
If we
hisopos de lengua.
compare with the swab,
También esta
with the
recomendación
tongue
se
swabs.
aplica para adultos y
This is a
adolescentes que
recommendation
viven
that
con
also
VIH.
applies for
Sin
adults
embargo,
and teenagers
recuerden
that
que ya
live
desde
with
reportes
with
anteriores la
HIV.
OMS nos ha
But do remember
recomendado
that
que
in
para
prior
personas con
guidelines,
VIH
WHO has
se
recommended that
recomienda
for HIV
realización de las
patients,
pruebas
it is
concurrentes o
recommended to use
simultáneas
concurrent
o
or
unas pruebas
simultaneous
de
testing
amplificación de ácido nucleico de
with
baja complejidad
low
y la prueba de
complexity nucleic
lipoarraynoma
acid
nano es la
testing,
estrategia
and the
preferencial.
LF-LAM
Ahora,
is
en el
the
contexto de
preferred
pruebas
test.
concurrentes,
Now,
donde no
in a
existan
setting
o no
of
estén
concurrent
disponibles
testing,
las
when there is
tecnologías o las
no
metodologías de
LANATs
baja
available,
complejidad
then
y
the
ácidos nucleicos, se pueden utilizar
use can be
estas
given to
metodologías cercanas al punto de
this
atención
MPOC and AF
conjuntamente con la prueba de
NATs technologies
lipoarraynoma nano
together with
cuando no se puede obtener una
LF-LAM
muestra
when
respiratoria.
a
También se
breathing
podría
sample
utilizar
cannot be
un
obtained.
hisopado de lengua
So you
con
could
la
use
prueba de
also a
lipoarraynoma
tongue
nano.
swab
En
with
el
the
caso, si hacemos una
LF-LAM.
extrapolación o extrapolamos
If
a niños
we
a esta
extrapolate this
recomendación
to
para su uso
children
efectivo,
and the
ya
recommendations for the use
bien
in
sea para
sputum,
esputo
either
expectorado
for
o inducido,
expectorating or
no se
induced,
para
us, there
realizar
aren't
los hisopados de lengua
sufficient
en niños o
testings
para otras muestras pediátricas.
for this
Siempre que esté
done in
disponible.
children
En
or
el
other
caso
pediatric
de
testing.
niños con VIH, la prueba concurrente de
In
preferencia
children with HIV,
mantenemos con las
the
pruebas de
preference
amplificación de
test
ácido
is
nucleico de
the
muestras respiratorias IDS, además de la
IDSs and the
determinación
mpox
del
NATs,
antígeno
in addition
lipoarraynoma.
to the
Como
determination
las
of the
metodologías de esta
antigen.
clase cercanas al
Since the
punto de atención
methodology
no
or the
proporcionan, recuerde
classes
que
that
les
are close
mencionamos
to
que
the point
solamente
of
nos permiten
care,
la detección
remember that
del
they are
complejo
only allowing
tuberculosis
us to
y
the detection of
no
the
nos
TB complex, but they do
da
not provide
resultados
results of
de
resistance
correlación a la resistencia a la rifampicina.
to
Todos los resultados que resulten
rifampicin, then all
positivos
results
deben
that
ser
may show
remitidos a
positive need
pruebas
to
de
be
resistencia.
referred
Es muy
to
importante
resistant
contar con un
tests.
sistema
It is
de
very important
referencia
then
de
to
transporte de
have
muestras
a good
eficiente, de manera
reference
que
system
donde quiera
of
que estén
transportation
ubicados
of
los
tests
minidot o esta
so that wherever
metodología,
there's a mini dot or
resultados
this
positivos puedan
methodology
ser derivados
where
muestras
we have
para la
positive results, we
realización
can have the
o el
way to refer
descarte
these
de
tests
resistencia
to
al menos
rule
a
out any
rifampicina.
resistance at least to
Aquí vemos
rifampicin.
resumido las evidencias
Here
que
we
han
have
existido para esta
summarized the
recomendación,
evidence that
que es
support this
muy
recommendation of
preciso
mpox
con
NATs,
relación
which is very
a la recolección
precise
de esputo de
in
una
terms of
sensibilidad
the
de
collection of sputum,
95%,
with a
ya con el hisopado de
sensitivity
lengua la
to about
sensibilidad disminuye un
95%,
76%, por
a
eso decimos que sigue
specificity
siendo de
of over
preferencia la
97%.
toma
That is
de
why we
muestra, en este
say
caso de esputo,
that
siempre y
the
cuando se
sputum
puedan
sample is still
recolectar.
the
Y
preference
con
as much
relación a
as
los
it can be
requisitos de recursos
collected.
y
And
rentabilidad,
in
vemos
terms
que esto
of
representa,
the
esta metodología
profitability resources,
representa
we
una
know that this
reducción del
methodology
50% de
represents
los
a
costes
reduction of the
en comparación
50% of the
con los
costs
métodos de
when we compare
amplificación de
it
ácidos
to the
nucleicos de baja
costs
complejidad.
of a low complexity testing.
Otras consideraciones que debemos
Other
tener en cuenta
considerations that
es
we need
que
to keep
la
in mind
recomendación de estas pruebas cercanas
are
al
that the
punto de atención
recommendation of these
como
mpox
diagnóstico
NATs
inicial para la
as an initial
tuberculosis
diagnosis for
no
TB
reemplaza la
is not
necesidad
replacing the
de
need to
realizar la
perform the bacilloscopy for the monitoring of the treatment. And this is a valid recommendation. Remember that technologies or these NPOC technology were not being recommended for the monitoring of treatment, which is still having the bacilloscopy as the most important one. When the test is done outside the labs, then training needs to be provided to the healthcare staff in terms of the recollection of testing. It doesn't need to be a very extensive training. With the minimum training, they can learn how to take the collection of the samples. When services are provided in the peripheral areas, it needs to be given a guarantee of bringing the proper services and the participation of the civil society and the community for the early detection and the generation of demand for the test, service providing, and monitoring.
So this is a question in regards to the lab personnel in biosafety, and the swab-based tests represent a risk of biosafety equivalent to the bacilloscopy. Therefore, we don't require the need to use biosafety booths. In the places that use battery energy, we can have backup batteries to avoid interruptions of the electrical service and the initial clinical treatment or management of people who cannot produce any sputum and that are positive for this test through tongue swabs must be done without having to wait, without having to do a sensitivity culture. And this positive result through this methodology is an indication for a timely treatment. In regards to the advantages of this type of care in the close point of care, is that they can be done in peripheral labs, as we had mentioned, in labs where we were doing bacilloscopy and primary care in mobile units or community centers that don't have labs with a specific infrastructure, and can be done by health professionals with basic techniques. They can be used with sputum swabs as tongue samples, expanding the access to tests. They produce results in less than 60 minutes. It can be used to detect other diseases, as we were mentioning before. And in regards to cost, it's much less expensive than other recommended diagnoses because, as I was mentioning, remember that the cost is $3.60 per test, and the sum of the two pieces of equipment is $335. In regards to limitations, we see that it's less sensitive than those with low or moderate complexity. And sputum, 85% versus 90%. The tongue swabs are less sensitive than the collection of sputum samples, 76 versus 85%. It doesn't detect resistance, therefore we need reflex tests with other types of tests or samples to detect resistance, at least to rifampicin. And we require the personal protection equipment for tongue swab, as we were mentioning before, and it's based on an instrument that requires two instruments with batteries like Puff Life and Minidub, and the transfer of the sample can cause contamination. Therefore, it could give us a false positive result for when we analyze samples in arrays. Here we see the recommendation for the use of tongue swabs and the methodologies of amplification of automated nucleic acids of low complexity. In this case, we see how the TrueLab can use tongue or sputum swabs. We see the methodology that is where we mix the sample and later the lysis sample in the TrueLice is transferred and incubated, and then later it's deposited in the chip to transfer the test. And this lysis procedure requires the TrueLice instrument that is not compatible with the TruePret devices. Therefore, the recommendation for TrueNut is the latest one, and we need the precision pipette of one single volume to transfer the sample to the chip to test by the qualified professionals. And the amplification procedure based on real-time PCR and the TrueLab devices are the same that in TrueLab MTB Plus what is different from the latest version is the use of the true lice for there to be the lysis of the sample. The recommendations of the tongue swabs for methodologies or low complexity classes is for adults and teenagers with signs and symptoms of TB that can be used in respiratory samples as an initial diagnosis test, as a substitution for the conventional methods of bacilloscopy and cultures. And also, when we cannot obtain respiratory samples, there are still the lesion samples because of their sensitivities, and the technologies of amplification of nucleic acid in tongue swabs can be used as an initial diagnostic test. Therefore, they meet with the criteria for tongue swabs, the expert MTB Ultra, TrueNet Ultima, and the diagnosis, the precision of the diagnosis varied because it had a lower sensitivity than the previous kinds of tests. And this must be reserved for situations in which we cannot obtain sputum due to a lower sensitivity. The simultaneous test, for the case of people who are living with HIV, we follow the recommendation of the simultaneous tests in amplification of nucleic acid in respiratory samples and urine. And if it's not possible to obtain the sputum test, it can be based on a tongue swab in the case of children living with HIV. And we recommend the methodology of low complexity nucleic acid. And remember that in the case of children, we don't recommend tongue swabs as part of the strategy of simultaneous testing. And even though there's no data on the detection of resistance to rifampicin by the use of tongue swabs, the recommendation was extrapolated to be able to be used in the Expert Ultra cartridges. In regards to the diagnosis precision, we see that it's very precise. It's a 90% sensitivity when we use sputum based on tongue swabs. It reduced to 71%, and in relation to the costs, we see that it's profitable in comparison to bacilloscopy, especially for people living with HIV. Other considerations in regards to tongue swabs or swabbing, we see that the initial clinical treatment for people who cannot produce sputum and are positive in MTB through tongue swabs need to be done without the need, or it's not required to have results both of the culture or the sensitivity test. And the instruments of low complexity that are automated both Gene Expert as mobile TrueLab, supported by a TrueLice instrument for the processing of the samples, can be used to analyze tongue swabs, respiratory samples, and other types of recommended samples. And this is a recommendation for the sputum groups. We're not going to delve into this explanation. So we need to go into the detail of what contributed to the evidence to this recommendation. Let's hope that this recommendation is a two-step strategy with a step one done by the sputum group. It's for up to 4 samples. And later, step 2 is based on the results obtained. And if it's negative, the result of the group of the 4 sputums, we don't do any more samples. And if it's positive, we must use individual samples to be able to identify which was positive. The recommendation is for the use of the sputum group when the limitations and resources don't allow individual sample testing in adults and teenagers with signs and symptoms of tuberculosis. It is recommended to use this methodology of amplification of low complexity nucleic acid of up to 4 samples as an initial diagnostic strategy to identify TB instead of individual samples. And this applies to Expert Ultra. And now thinking about people who are living with HIV in children and people with greater resistance to medicines, they should not be assessed with a strategy of grouped samples, but it should be done for individual testing due to the reduction of sensitivity of the people who have a greater risk. There's evidence available both for induced sputum and look at the savings of the costs of the use of this implementation of this group. And remember that the range of costs can be from $7.97 to $11. And when we take a look at the range, this can be reduced from $3 to $9.95. This has been done with positivity lower than 24%. And here we can see the case of tuberculosis, both for sensitivity in individual and group sputum, both for individual sputum, and the methodology is close to the point of attention. And we see how the sensitivity of what we know is at 90% for the case of expert ultra and can reduce up to 85% in the case of group sputum. And when we talk about mini, it reduces to 85%, and the specificity has an added value. When we see that tongue swabs and low automated complexity, we see that this varies from 71% to 76%, meaning that there's greater results in sensitivity in the point of tongue, and the specificity is maintained at elevated values. As conclusions, the use of molecular platforms close to the point of care are going to allow a decentralization of the diagnosis, a reduction of time of diagnosis, a sustainability, because it requires less infrastructure. The use of tongue swabs in automated platforms of low complexity is an ideal option when the person cannot produce sputum. It improves its acceptance and adherence, and it's going to facilitate community strategies. And it can also be done by personnel with basic training. The last recommendation, the use of grouped or pooled samples is a more efficient use of resources. The increase of diagnosis capacity maintains a diagnosis yield and supports programmatic planning. As final messages, the 9 recommendations will be allowed to close the gaps of molecular diagnosis, reduce geographic and social inequities, optimize costs without sacrificing diagnosis quality, and strengthening the national response for TB and resistant TB. And of course, advance towards the objectives or the end of TB strategy of WHO. At the bottom, we see that recently the WHO and the World Initiative of Glee Labs has published a toolkit that can be downloaded, or that they recommend procedures and quality controls and monitoring and evaluation, training, standard operating procedures to be able to implement this technology. And here we have the recommendations, the 3 recommendations that were published by WHO in their fast communications. Thank you so much. And we thank the Department of HIV, TB, Hepatitis, and TSS of the WHO and the diagnosis team for providing some of the slides that were shown today. Thank you so much.
Muchísimas gracias. Perdón. Muchas gracias, Ernesto, por la presentación de las nuevas
Thank you so much,
recomendaciones.
Ernesto,
Recordarles
for
que
the
vamos a
presentation
compartir la grabación y
of the new
materiales
recommendations.
posteriormente, y
And we
también
will be sharing the
recordarles que
materials
tenemos
later. And I wanted
el
to
espacio
remind you
de
that we have the
question and answer, de
space
preguntas y
for
respuestas que
Q&A
pueden seleccionar abajo en donde están los
that you can
iconos, y hay
select
algunas preguntas
at
muy
the bottom and
interesantes.
the
Agradecer
icons.
a Patricia que está apoyando con la respuesta. Posteriormente
And
también
this is,
tendremos un
we're
espacio
going to
para
be supporting
preguntas
Patricia with questions and answers.
en vivo.
And we will be supporting for live questions.
Seguimos con la agenda. Now it's my pleasure to introduce our next speaker. And we are very pleased to have with us Marian Touré from Unitaid. And as I mentioned before, Unitaid has played a key role in supporting the generation of the development of evidence behind all these innovations and recommendations that we are discussing today. Marian will present the Start for All initiative and above all the priorities for Unitaid. So Marian, thank you so much for being here with us. The floor is yours.
Okay. Gracias, Pedro. Gracias a todos. Buenos días. Gracias a la UPS y la
Good
OMS
morning. Thank you so
por
much
convocar
to
esta
PAHO
importante discusión
and
sobre las
WHO for
recomendaciones
calling to such an
actualizadas
important
para el
discussion
diagnóstico
on
de
the
la
updated
tuberculosis.
recommendations for the diagnosis of
Es un
TB.
placer unirme
It's
a
a pleasure
toda la región
to be
y
here
al
with colleagues
consorcio
from the
SAFRO
entire region and the
para
consortium to be able
reflexionar
to
sobre lo que
reflect
significan
upon
estas
what
actualizaciones
these
para la
updates
implementación
mean for
concreta.
the
Con
implementation
la
in the real
orientación
world.
que evoluciona, la pregunta clave que se
For
convierte no
the
solo en
evolving
lo que
guidance, the key question
funciona, sino también en lo que se puede
in what
ofrecer a
works and
escala
especially what can be
en
offered
entornos de
to
atención
scale
primaria y
in terms
comunitaria,
of
donde
primary
las
care and
limitaciones son
community
reales
care,
y
where there's
persistentes.
real and persistent
Desde la
limitations.
perspectiva de Unitaid, las
From
prioridades
Unitaid, the
es asegurar
priorities
que la evidencia se traduzca en
are
enfoques
to
implementables
ensure
y
that
estrategias
evidence is
diagnósticas que
translated
los
into
países puedan
implementable
adoptar
focuses
y
and
sostener
diagnosis
y
strategies
observar
that the
de manera realista.
countries can adopt and
Por lo
sustain and
tanto,
scale in a
nuestro
realistic manner.
enfoque en el
Therefore, our
diagnóstico
focus
es bastante
in the
claro,
diagnosis is
apoyando
very clear,
enfoques que amplíen el
supporting
acceso
focuses that
al
expand
diagnóstico
access
oportuno, la
and
vinculación
have
y
a
atención,
timely
fortalecer
diagnosis
las
and
condiciones
strengthening
para la integración
conditions for
sostenible
the
y
integration,
equitativa
sustainable
de los
integration
diagnósticos en
and
los
equitable
sistemas de atención primaria de salud.
diagnosis for
Entonces,
primary healthcare
el tema
services.
central es asegurar que las innovaciones
So,
ayuden
a
a los
central
países a
matter
hacer más
is
con los
to
recursos
have
disponibles
organizations
sin
help
comprometer
countries
la
do
calidad
more
y
with
la
the
equidad.
available resources.
Este es exactamente el espacio que
And this is
SARFRO está
exactly the
diseñado para
space
abordar.
that is
Lo
done
que
and it's
hace
designed to address.
lo que hace que la iniciativa SARFRO sea
And this is what
particularmente
makes this
relevante
initiative be
para la
really
discusión de
relevant.
hoy es su enfoque en la
And for
evidencia
today's
para
discussion,
la
there's
implementación.
an evidence-based
Entonces, no
focus to be
solo
ready
si
for
las herramientas
implementation.
funcionan, sino cómo se
Um,
pueden usar juntas de
and
manera que sean factibles para los
This
programas.
is done in ways that is feasible
El
for
proyecto
programs.
ha generado y
The
aportado
project has
evidencia
generated
sobre la prueba colectiva
evidence
de
on the
sputum,
collective
como ha dicho
test,
el colega.
as
Esto
our
ayuda
colleague
a
was saying,
definir vías prácticas
and this
para
is
las innovaciones
helping
como
define good
agrupamiento,
practices
las
like
combinaciones de
pooling
diagnóstico. Pueden apoyar
and the
un alcance
diagnosis.
ampliado de las
They can
pruebas
support an
locales,
expanded
particularmente en
scope
entornos
of
con
specific
recursos
tests with
limitarios.
limited
El
resources.
mensaje de Unitaid es simple.
The message of
Las
Unitaid is
directrices
simple.
tienen el mayor impacto
The
cuando se
guidelines have a
combinan con
greater
soluciones
impact when
implementables.
they are combined with
Nuestro papel
implementable
junto con
solutions,
los
and our
socios
role
es
together with the
asegurar que los
partners is to
países no
ensure
solo
that the
estén
countries
equipados con
are not
recomendaciones,
just
sino también
equipped
con
with the recommendations,
evidencia
but also
y
with the
enfoques que se
evidence
puedan
and
traducir
focus
en
that
la
can be
práctica.
translated into
Mientras
practice.
escuchan las
And
próximas
while you listen
presentaciones,
to the
les
next
animo a considerar
presentation,
no solo el desempeño,
and
sino
not
dónde
just
y cómo se
consider
pueden
not just
aplicar estos
performance, but
enfoques para
also
fortalecer
where and how
los
these focuses
programas
can be applied
nacionales y cerrar
to
las brechas
strengthen national
diagnósticas
programs
persistentes.
and close the
Gracias
persistent
nuevamente a
diagnosis
UPS,
gaps.
a la
Thank you so
OMS
much
por
once again
liderar esta
to
agenda.
PAHO for
Gracias
to
a
the
los socios de SAFRO
WHO for
para
leading this
aportar este
agenda. Thank
importante
you
trabajo.
to the partners for
Me
advancing
detendré aquí
this
para que
work.
escuchamos la presentación del proyecto SAFRO. Gracias,
And
Pedro.
this is thank you so much for the presentation of this project. Thank you, Pedro.
Thank you so much, Marian, for your words and for being here. And as I mentioned before, for all the work you are doing on this field. Vamos a continuar con la agenda
We are going to
y
continue
como
with the
comentaba y
agenda,
anunciaba
and
Marian, a
as Marianne was
continuación,
mentioning, we
el
now
colega
have
Tom Winfield de Liverpool
our
School
colleague
of
Tom
Tropical
Wingfield from the
Medicine. Tom,
Liverpool
es
School
un
of
placer
Tropical Medicine.
tenerte aquí
Tom,
con
it's a
nosotros,
pleasure to have you
agradecerte
here
de
with
verdad
us. I want to thank
por
you
el trabajo conjunto
for the joint
y
work.
Tom va a introducir el
Tom will be
proyecto Star
presenting
for All.
the Start for All project.
Tom, adelante, el
Tom,
micrófono es
the
tuyo.
floor is yours.
Muy buenos días
Good morning, good afternoon, everyone. Thank you so much to my colleagues from PAHO, Ernesto and Pedro, for the invitation to such an excellent webinar and for the opportunity to present our findings for the Start for All project. And I want to say from the beginning that this presentation is product of the work of many people and products from the national TB programs, labs, communities, Unitaid, Stop TB, and PAHO and WHO, and the implementation teams from the 7 countries. I am Tom Winfield. I am a physician, infectologist, and I'm a researcher at the Liverpool School of Tropical Medicine. And I am a main researcher of our project that's called Start for All. It's about starting to take action for the diagnosis of TB. And today we're going to be talking about grouped or pooled sputum tests for molecular diagnosis of TB with lessons from our experience in multinationals. And the central idea is simple. When resources are limited, we can analyze several samples together in one single molecular test, increasing efficiency and reducing costs. Okay, what are our objectives today? First, we are going to describe the concept of the pooled tests for TB, what they are, how they work, where they can be appropriate. Then we're going to summarize results of Start for All in 7 countries, not just diagnostic precision, but also savings in cartridges, costs, and operating viability. And third, we're going to go from evidence to practice, what needs to change in the lab, what does not need to change, and how can we maintain traceability, biosafety, and quality. And finally, we want to locate the pooled tests within a broader agenda with more efficient lab networks, with decentralized services, and more equitable access to molecular testing. Who are we? Start for All is a broad alliance. We have Stop TB Partnership, and where I work also, we co-lead the consortium, and we are lucky to collaborate with many partners, excellent partners, even in Nigeria, Gen Health Foundation in Brazil, Universidad Federal de Sergipe, led by Dr. Santana Santos, who will be presenting about his experience today with communities from Brazil. In Malawi, the Malawi Liverpool Welcome Program. In Cameroon, Center for Health Promotion and Research. In Vietnam, Friends for International TB Relief. In Bangladesh, ICDRB. In Kenya, the Kenya Medical Research Institute and the USCDC. We thank all these partners for their collaboration, and it's important to highlight that Start for All is not just a technical study or a lab study. From the design, we have the participation of scientific advisors, national programs, and communities affected by TB, because any diagnosis strategy needs to be precise, but also acceptable, feasible, and useful for the real health systems and the people who live there. So, what is Start for All? It's a project in which we assess algorithms for screening and diagnosis in context with different profiles, epidemiological profiles, even with high burden of TB, or TB and HIV, or multi-resistant TB. And the goal of Start for All is to assess one single isolated test. It's not to assess one single isolated test, but understand what combinations work better at different levels of the health system. I want to acknowledge proudly the leadership of our founder and friend and colleague, Professor Luis Cuevas. May he rest in peace, and many colleagues that have driven this focus of multicentric and pragmatic assessment. What were the goals of phase 1 of Start for All? In phase 1, along 2024 to 2025, We assess diagnosis precision, cost, viability, and susceptibility of selected tests and algorithms, and we focus on the lowest levels of healthcare, meaning primary care and hospitals, district hospitals, and key populations that are not attended in community environments. This is important because these tests, pool tests, can be very attractive when we want to expand the molecular access to the population and when the access is low or moderate, but when doing individual tests on everyone could be very expensive and therefore not possible. In total, we recruited 14,741 participants during phase one. First, they see that we include more than 9,000 people that attended primary care services and outpatient consultations of hospitals of the district in Bangladesh, Kenya, Cameroon, Brazil, Malawi, Vietnam, and we searched for cases in the community where we recruited over 5,000 participants of vulnerable populations, like displaced population, people who live in informal settlements, rural populations, urban populations that are vulnerable, and nomad groups in Nigeria. As we can see, we included almost 1,000 children participants. And I say that the diversity of our participants was a strength of our project that allowed us to assess the performance of algorithms in scenarios closer to the practice. So what were the tests assessed for Start for All? We assessed screening tools like C-reactive protein, the Fujilam test, and chest X-ray assisted by artificial intelligence, called here CAD-RX. We also did diagnostic tests, molecular diagnostic tests with the sputum sample of participants first, and Dr. Anna will be explaining more in the next presentation. We did expert ultra pooled sputum. To be able to do this process, we combined 4 samples of sputum and 1 single cartridge, meaning mostly with a proportion of 4:1, but with groups of 2 or 3 when the workflow required it. As a small explanation before the next talk, the principle of pooled sputum test is that the group is analyzed first. If it's negative, all the individuals in the group are reported as negative. If it's positive, we do individual tests to confirm the diagnosis. But in Start for All, as a study evaluating the precision and performance of group tests, we did expert ultra individually in each participant, independent from the results obtained, using information from using the remains from the first sputum sample. The culture was a standard of reference, and we gathered a second sputum sample to do this culture in each participant. And in this webinar today, because of a lack of time, we're only going to be focusing on the results of the pooled tests. So, which were the key messages of phase one? First, as you're going to see in the next presentations, the algorithms that combined X-rays with expert ultra that were pooled had had great or high diagnosis precision. Then these pooled samples showed significant savings in cartridges, but in a small detection reduction, like 3% less sensitivity compared to individual tests. Third, the message of equity, as Marian was mentioning, is crucial. Savings only improve access if the cartridges and the resources that are freed up are invested on doing more tests on more people. And informed by our results or those of other groups, the WHO did a conditional recommendation, but with high certainty of evidence for molecular tests that are fast and automated and low complexity in grouped sputum samples. When limitations of resources prevent from analyzing each sample individually. Following our productive work in phase 1, our team really wants to start phase 2 of Start for All, which will implement and assess the best algorithms with people who are symptomatic and asymptomatic in communities and health centers in 5 countries. Now, to close, the team developed the kit of Start for All on pooled tests. It's open, it's free for national TB programs, and my colleague Anna will be presenting more on that. My recommendation, my practical recommendation is not only to start with a pooling abstract idea, but to think about the kit, to think about step by step.
Thank you all very much for attending this webinar, to the organizing team and all partners, colleagues, and to all those patients affected by TB that have helped here. And I'm open to any questions and the sharing of experiences. Thanks a lot.
Excelente, Ton. Muchísimas
Excellent, Tom.
gracias. De verdad, mil gracias por tu presentación.
Thanks a lot for your
Gracias por el
presentation
resumen de
and
la
the
investigación
summary
del
of
consorcio Start
this
for All.
research
Tan
and the
importante la
Start for
investigación
All
que realizan
consortia.
para seguir
It is very
mejorando
important
tanto el
to
testeo
look into this
como el diagnóstico,
research to
el
be
tamizaje como el diagnóstico.
looking
Hoy,
at
como
the
decías, vamos a
analysis, the
estar
screening,
enfocándonos
the diagnosis, the
principalmente
testing. And today,
en
as you
el tema de
said, we are
muestras de
going to be
esputo
focusing most
agrupadas, pero tenéis
particularly
mucha más
in
información
the cluster
del
sputum
proyecto y
testing,
de
and
las siguientes fases
we'll be looking at
que se
the
realizarán del
next
proyecto,
phases the
y
project would
esperamos
bring,
poder conocer más en los
and we
próximos
expect to be
webinars.
able to learn
Gracias, Tom.
further in
Continuamos y,
future
como
webinars.
mencionabas,
Thank you,
vamos a seguir
Tom.
profundizando.
And as
Ahora la
you've
doctora Ana
mentioned,
Isabel
we'll
Cuevas
continue
Atienza, también
analyzing,
de la
and now we
Liverpool
have
School de
Dr.
Tropical
Ana
Medicine,
Cuevas
va a
Atienza
presentar
from
conceptos
the
de pruebas de
same
esputo
Tropical
agrupadas
School
y
of
el
Medicine,
resultado en
talking
el
about
rendimiento diagnóstico y
this testing and the
eficiencia
diagnostics
en la experiencia que
performance and
tienen en los 7
efficiencies and the
países de
experience
Start
the
for All.
7 countries have
Ana,
in the Start for
Isabel,
All.
un placer. Adelante,
It
por
is a
favor.
pleasure, and go ahead,
Hola,
Ana.
muchas gracias.
Hello, and
¿Pueden
thank you very
confirmar si
much.
ven mi pantalla?
Please confirm if you can see my
Sí,
screen.
se ve perfecto.
Vale, muchas gracias.
Okay,
Bueno,
great.
primero,
Okay, so
muchas
first of
gracias
all,
por la
thanks a
invitación
lot for
y
the
por la
invitation
oportunidad de
and for
compartir
the
hoy
opportunity to share
lecciones
with you
aprendidas
about
sobre
the
las
lessons
pruebas
learned
agrupadas de sputum
on the
para
pooled
el
sputum
diagnóstico
testing
molecular de la
for
tuberculosis.
molecular
Mi
testing of
nombre es Ana
tuberculosis.
Isabel Cubas
I'm Ana
Atienza y
Isabel
soy
Cubes Atienza,
coinvestigadora del
and I
proyecto
am a
Start for All.
researcher from the Start for
Soy
All
profesora
a
titular
project.
en diagnóstico
I'm
de
a
enfermedades
head
infecciosas
professor in
en
the
el Liverpool
diagnosis of
School of
infection diseases
Tropical Medicine
and the Liverpool
y
School of
esta
Tropical Medicine.
presentación se va a centrar especialmente en
And
tres
this
aspectos.
presentation will
Primero,
consider
que es el
particularly
concepto
3
de
aspects.
pooling,
First of
que
all,
Tom
what is
ya
the
ha dicho un
pooling
poquito,
concept
pero
that
voy a ir
Tom
un
had
poquito más en
referred to a
detalle.
bit, but I'm going to go a
Y
little further in
también
detail.
vamos
And
a
also, we're
enseñar
going
más en
to, I'm
detalle
going to be
los
able to show you
materiales de
also more detail
capacitación
about the
que
training
hemos
materials that
desarrollado
we have
para apoyar la
developed to
implementación.
be able
Y
to help in
tercero,
the
cuáles
implementation.
han
And
sido los
third,
resultados
which have been
principales de
the
Start
most
for All en
important
términos de
results of
precisión
the
diagnóstica
Start for All in
y
terms
eficiencia.
of diagnostic
Voy a comenzar.
precision and efficiency.
Primero quisiera
And I'm going to
explicar el
start. First
concepto
of all, I'd like to
general de
explain
las
the
pruebas
general
agrupadas.
concept
La
of the
idea
pool
inicial
tests, and the
principal es
initial
súper
idea
sencilla
here is
y
quite
consiste en lugar de
simple, and
analizar
it
cada
consists
muestra de
that
esputo
instead of
de manera
analyzing
individual, desde el
each
inicio
sputum
combinamos
test
pequeñas
individually,
cantidades de varias
we
muestras
put
en un solo
together
grupo o
small
pool
quantities
y
of
analizamos
several
ese
tests
grupo
in
con
one
una
same
prueba
group or
molecular,
pool of tests, and
como
we
el
analyze it with a
Tuberculosis.
molecular testing
Si
as
el
Gene
resultado del
Expert.
grupo es
If the
negativo,
result of the
entonces
group is
asumimos
negative,
que todas las
then we
muestras
assume that
individuales
all
incluidas
individual
en ese
tests
grupo son
included in
negativas.
that group are going to
Eso
be
permite
negative.
ahorrar cartuchos,
This
tiempo y
allows the
recursos.
saving
Si
of
el resultado
cartridges,
del grupo
time,
es
and
positivo,
resources. If the
entonces
result
volvemos a
is
analizar
positive instead, then
individualmente las
we're going
muestras
to
que formaban
analyze the
parte
samples
de ese pool
individually, all
para
the samples that were
identificar
part of that
cuáles
pool,
o
to be
cuál
able to
son
identify
positivas.
which are positive.
Ahora les voy a mostrar
Now I'm
de una
going to
manera
show you
gráfica
in a graphic way what the pooling is all about. Here we find an illustration. On the left, we find 4 people. Number 4 person is a person infected with tuberculosis, while the other 3 are negative. So what we do is we mix a test of each of these individuals into one group or pool, and this is a sample that is then processed with the molecular platform, normally as an individual sample should be processed. So the result is positive in this case because one of the samples was positive. So then we proceed to the initial sample to test individually each of the samples. On the right side, we find the other scenario where we have 4 people that don't have tuberculosis. So what we do is we mix one sample of each of them to put together the pool. It is processed and the result is negative. And when the result is negative, we do nothing else because we assume they are all negative. This is an approach that is known as two-phase Dorfman, or is also called hierarchy pooling. And it is a classical pooling method where you analyze the group first. And then if the group should show any positive, that's when you analyze the individual samples. So pooling does not replace the individual diagnosis of positive pools, but it actually works as an initial strategy to be able to reduce the needed tests to the smallest numbers, and so it works as a screening test. The WHO recommends the pooling tests under specific conditions when resources are limited. The most important reason is because it expands access to molecular TB testing. By using less cartridges with the same budget, then we'll be able to analyze more people. Also, by using less cartridges, we are reducing waste. For instance, toxic substance as guanidine deoxynide, which is a chemical toxic substance for water environments. It also reduces the working load for the lab because they end up analyzing less cartridges. But when you use the pool testing, then the key conditions need to be when positivity is low to moderate, with a recommendation of being less than 30%. This is because positive groups, they will all have to be reanalyzed individually. So if positivity is too high, we're going to have to analyze individually a lot of samples. So under situations where positivity is high, this technique could be actually counteracting. The actual volume of the sputum is more than 1 milliliter. And sufficient volume is recommended so that the pool testing can be done better. And if positive, to have sufficient sample to then repeat that testing individually. And the third key condition is for the lab to have the capability to give tracking to the identification of individual and pool samples. In the implementation of these pool testing, we have the typical settings of community screening, community sessions in the search of active cases, and last, we high processing capacity. Particularly the community screening and the community journeys of active cases when the positivity is low and many samples are analyzed. Now, when not to use the pooling testing? It is not recommended when we have non-validated samples, like for instance, extrapulmonary samples. The evidence right now on that is only for sputum and with GeneXpert. It isn't all recommended when you need to know what the individual result is immediately. For instance, if there's a risk of pharmacoresistant TB, this is due to the delay of having to go back to test in the case of a positive group result. So when the result demands immediate approach, then it's best to do it individually. And also, the pool testing is not recommended upon the risk of postbacillar risk tuberculosis. That means that when the bacillus load is way low, which can occur with children or those that are living with HIV or people who had been previously treated with tuberculosis treatments. I am now going to talk about some of the concepts that are wrong. For instance, the first wrong concept is the pool testing have a low diagnosis precision via dilution, which is not true. It is true that there's a lower sensitivity, but this reduction in sensitivity that we'll talk about in a minute is focusing in those samples with low bacillar load. And that low in the precision is compensated upon analyzing a lot more people. Truth is that pool testing have a lot of precision when standardized and used in the proper settings. Another wrong concept is that it is a complex and slow technique that requires advanced labs. That's not true. This is actually something that you can integrate in molecular platforms of low complexity that already exist on a lot of TB programs. Those operators that know how to run an individual test can easily implement these groups with slight modifications. What you do need is a clear workflow, the proper training, and a good traceability to the sample. And then finally, the last wrong concept is that pool testing generates stigma, inequality, and they demand multiple samples and visits. When the reality is that pool samples expand the access to molecular TB testing while keeping the confidentiality just as much as individual ones. And as we have stated before, if the initial sample is sufficient, you just collect 1 milliliter and you don't need any more patient visits and you don't need to take any more samples either. This QR code is of a paper of one of my colleagues, Vivolem, if you want to learn a little bit more about pool testing. I am now going to go to what are the training materials. In Star for All, in addition to generating evidence, we have also developed practical materials to give support to the implementation of pool testing. And so we designed a toolkit that we call the pool kit. This toolkit is mostly addressed to those that are healthcare staff in labs, healthcare personal tracers in tuberculosis, so that they can understand and implement the method in a standardized manner. It includes protocols that have a good detail of it, checklist of the preparation of places, the case study, a visual poster that shows a step-by-step in how do these pool sampling and this pool testing, and it can be posted on the lab wall. There's a section with frequent questions. And there's a presentation of training. It is a presentation that you can use as material to train screening teams and lab teams in eligibility preparation, analysis, and interpretation. And it is available for free online. All you need to do is you take this QR code or you go to this link and then download it. Right now it's only in English, but for the future, we have thought about being able to translate it into other languages. And very shortly, I'm going to show you a video of Stop TB, which offers a clear guide and a step-by-step on how to run the method of pool testing, which is ideal to train the healthcare staff and to give support to an implementation that is equal among teams. This is a video available in English, Spanish, and French. I'm just going to play the video in Spanish right now. Collective pool testing is a method that reduces cost per person and increases access to tests. WHO has recommended to carry on this testing for tuberculosis, and the labs have the previous experience to conduct them. This video shows how to conduct this pool testing for the trial of expert, how the pool testing works. Before we start, make sure the volume of sputum is more than 1 milliliter. Prepare the samples that you're going to pull. We're going to show you how to analyze 3 of them, introduce numbers of ID numbers of patients. The reactants are for samples expert is what we're going to see here with the new pipette scenario. I'm sorry, we cannot read the whole material. It was way too fast. Mixing well to help incubation, 10 minutes. Mix well and let rest for 5 more minutes. Label the new recipient with the identification of the group. Add 1 milliliter of mixture to each individual sample to the recipient of pool tests. Avoid contamination of surfaces. Label the cartridge that will be used for the pool testing with the identification code of the group. Analyze the combined test as a normal sample. Extract the liquid sample above the line of 2 millimeters and slowly let it go through into the cartridge. Scan the cartridge, introduce any patient's information in the expert instrument sample, and proceed to load the cartridge. Waiting for results. MTB not detected. To be reported that no MTB has been detected. Report of results. Notify to each individual. It doesn't need to conduct any more testing and wait for results. If any is detected, then individual tests need to be conducted. In any degree where the sample MTB is detected, each sample needs to be tested individually. For each individual testing, label the new cartridge with the identification of the individual sample, just as in the individual recipient. Use the remaining mixture of the sample or individual reactant to each recipient into the initial one. The mixture must be used within 4 hours to be stored and is stored to a temperature and it needs to be stored to 24 hours. Analyze the sample as usual and introduce results. If the sample result is not valid, error, or without a result, then you must repeat the same steps. This video has been provided by CHPR together with PNT in Cameroon, working together since 2020 with this. I expect you've been able to enjoy the video. I am now going to go to the Start for All results, which is the last part of this presentation. And it is an important part because it helps us answer two practical questions. The first one is, how good does pooling work as when compared with individual testing? And second, how much can we save in terms of resources when we use this strategy? We're now going to go to tell you shortly about the study of Start for All Phase 1, which Tom has talked about a bit. So I'm going to go quick here. Start for All has been a multi-center perspective study of diagnostic precision, where we were able to put together over 14,040 people with valid pooling results. It was a recruiting that occurred between November 2023 to February 2025. And we were able to put together people from 7 countries: Bangladesh, Brazil, Cameroon, Kenya, Malawi, Nigeria, and Vietnam. We were able to also collect from different settings: primary care centers, district hospitals, community search of cases, and children in Cameroon and Vietnam. Children were attended in primary health centers and district hospitals. The index testing is Expert MTV RIF Ultra in groups of 2, 3, or 4. And we followed, as we've explained earlier, the Dorfman technique in 2 phases. When we do it in the pool, and then we repeat the positives. The comparing element was Expert MTV RIF Ultra individual. As reference standard, we use the microbacterium culture with the MG in all countries, but in Brazil when they use the enzyme. And I'm now going to show you the level of precision and the culture of Expert Ultra, both pooled and individual. Altogether, we put together 13,531 participants with full information from Expert Ultra individual, pooled, and culture. As you see, the sensitivity of the pooled sample as compared with the culture was 84.9%. The sensitivity of Expert Ultra individual when compared with the culture was 88%. As we can see, there is a difference only of minus 3.2% in sensitivity. But when we compare specificity, the pooled test was had more specificity as expected, because sensitivity is a bit lower, so specificity was 98.3% for the pooled testing, and for the Expert Ultra individual, 97.7%. Now, we're going to talk about the efficiency of the pool testing. In Start for All, we saved 51.1% of cartridges, and this was a global reduction that was found during the pool testing. This reduction includes groups of 2, groups of 3, and groups of 4 tests. It includes individual repetitions of positive groups and non-valid or error groups. Altogether, with the pool testing, we were using 7,028 cartridges versus 14,262 if they would have been individually analyzed. Here, we find a chart showing the observed reduction, which varies according to the size of the samples per each pool. So we find a greater reduction in the groups of 4 samples. In Start for All, 87% of groups were groups of 4, and as Tom explained, this is because of the design of the study. The study was designed to use samples of 4, But then out of practicality and effectiveness, when groups of 4 were not possible, we put together groups of 2 and 3. That's why we find more groups of 4. And something very important that I want to talk about now is that the cartridge reduction depends on 2 factors. The first one, as we can see, the size of the group. And the second, the positivity, as we talked about earlier. This follows the Duffman prediction that when positivity is high, there's less savings because we have to conduct most tests, we have to repeat more samples. But when positivity is low, as the community search of cases, there's already a self-saving. So I've given you these 2 links where you are able to find the Dorfman formula. And there's an application online, and it's quite practical because it's going to help you calculate the efficiency. And so all you have to do is you have to enter the size of the group and positivity of the population you're working with. And in the other way around, the formula could be used, for instance, if you already have the positivity of the population that you're working with and the efficiency that you need, where you'll be able to calculate the number of samples that you have to use. I'm going to show you now an example of what it looks like. This is an example of the Stop TB formula from my colleague Tuzard that has worked with this page. In this example, we find a very high positivity. We find a 25% positivity. And the size of the pool is 4. In this scenario, you can only save 14% of cartridges. In this example, on the right, positivity is much lower, with a median of 7.5% with the same size of pool, where you save 50% of cartridges. So if in the next example we are to use the same positivity and reduce the name of samples per group to 3, then it will be a saving of only 46% of cartridges. So you can use this in your lab to be able to see the efficiency of your method. Where does it work? Where does pooling work best and worse? I'm going to show you a chart that shows the positive matching of Expert Ultra in pool and in the individuals. The positive matching with, or total PPA was high, was 90.1%. Then we have the positive matching that has been stratified in several variables: per country, per pool size, per setting, per HIV infection presence, and for the bacillus load. If we look at the country variable, group size, or infection with HIV, PPA, or positive matching, did not vary so much from the total. But if we go to the kind of a setting, we can see that the community case search shows a much lower PPA when compared with the district hospitals and primary healthcare centers. What shows this important reduction is the bacterial load in this kind of settings. And so if we go to the bacterial load, we can find the percent. However, if we look at it in a very low or trace, which is the 2 last ones here, the matching went down to 55.4%. What that means is that non-detected cases or false negatives are concentrated on the extreme of the trace. And in the community cases search is where we find the have more false negatives. This is a finding that is very important for the implementation. Pooling is very efficient in community search, but we have to keep in mind that it is also a population where bacterial load is much lower. To take advantage of the pool sputum testing, we have to analyze a lot of people to be able to find more people that may be suffering from tuberculosis. Otherwise, we're going to lose them. The key message to wrap up here is, first of all, precision. We have found that the strategy of pool testing has a very high precision with 84.9 sensitivity, 98.3 of specificity versus culture in 7 countries. And so with just one reduction of 3% in sensitivity, and if we compare it with the expert individual, we know that this reduction in sensitivity is mostly concentrated in those samples that are traces that have a low bacterial load that is then compensated when analyzing more samples. We have also seen that efficiency in our study was 51%, and we were able to use 51% less of cartridges from expert when we used the pulse testing, meaning that if you have a fixed budget, you're going to be able to analyze almost twice as many people with the same budget. The savings can be estimated with the Dorfman formula. If you use the link I've showed you in the slide, according to the population positivity and the size of the pool. And then finally, the WHO recommends the sputum pool testing to be used because it expands access to molecular testing and reduces drastically the cost per test. By reducing that budget, it increases access to molecular diagnosis. And the loss in sensitivity is compensated by analyzing more people. And this, for instance, is in the community search of cases.
The central message is that the small loss of sensitivity is compensated at programmatic level if the pooling allows analyzing many more people, especially in active case search strategies. What matters is to understand that the goal is to expand the number of people who are analyzed with molecular testing. It's not saving cartridges, it's taking advantage of the savings of cartridges to be able to analyze more people with the same budget. The end is to analyze more people to find more people with TB. And to close, I want to thank the Star for All Alliance, all the teams of all the countries that have contributed to this work, and thank you so much.
Muchísimas gracias,
Thank you so
Ana
much.
Isabel. Clarísima
Ana
la
Isabel,
presentación
your presentation
y el
was
vídeo
very
también. Vamos a
clear,
compartir,
as
¿verdad?,
well
con
as
los
the video.
colegas
We are
estos
going to be
recursos
sharing these
realmente
resources with our
interesantes, todo
colleagues.
el
They
toolkit
are
también
so
que
interesting, all the
estáis
toolkit
desarrollando.
that you are
Bueno,
developing.
yo creo que el mensaje es claro, una estrategia
And I think
realmente
that the
útil
message is
que nos
clear.
va a
It's a very
permitir
useful
optimizar
strategy
recursos para el
that will allow
diagnóstico y
us
como
to
tú muy
optimize
claro has dejado,
resources
que
for
es
diagnosis.
un
As you
ahorro
have made it
para
very
poder
clear,
llegar a
it's a
más gente, ¿no?
saving to be able
Ya
to
hay muchas
get to more
preguntas sobre
people.
este tema. Vamos a
And there's a
tener,
lot more
después de la
questions on
última
this
presentación,
matter that we're
espacio para
going to
poder
be having
dialogar más sobre esto.
after
Así que
the
darte
next
las
presentation.
gracias,
We're going to be
Ana, y ahora vamos a
talking
pasar
about
entonces a
this.
la
So thank you,
siguiente
Ana, and we are now
presentación.
going to
El
go to
doctor
the
Víctor
next
Santana Santos
presentation.
de la
Dr.
Universidad
Victor
Federal
Santana
de
Santos from
Sergipe, en Brasil,
Federal
nos
University
va
of
a
Sergipe in
presentar
Brazil will present to
la
us
experiencia del agrupamiento de
the
muestras,
experience
del
of
pool
the
de
pooling
muestras de
of
esputo
samples, of sputum
en
samples
Brasil, en la
in Brazil,
investigación que han
and the
realizado.
research that they have done.
Víctor, es un enorme placer
Victor, it's a
tenerte aquí con
pleasure to
nosotros y
have
te
you
paso
here
la
with
palabra.
us, and I hand the floor over to you.
Bom dia a todos. Vocês conseguem me ouvir?
Good morning,
Y
everyone.
estamos viendo, pero te escuchamos un poquito bajo.
Pouco baixo. Melhorou agora?
Is it better now?
A ver, Víctor, disculpa.
Let's see, Victor.
Melhorou o áudio agora?
Did the audio improve right now?
Víctor.
Sí, se le escucha bien.
Yes, yes, yes.
Perfecto, gracias. Adelante, Víctor.
Okay. First of all, I would like to thank for the opportunity of doing this presentation. I am thankful for my colleagues from the Pan American Health Organization and the World Health Organization and the colleagues from Start for All for being here today. I'm Victor Santana Santos. I'm a professor of the Federal University of Sergipe, and I am a guest here of Start for All in Brazil. Today afternoon, I will be presenting the experience of a sputum group of the tests of sputum. The doctor's signal isn't very good. Can you see my screen? Okay.
Sí, se ve.
Here we have the conflict of interest statement. TB is a public health problem mainly in Brazil. It's in the list of the 30 countries with the greatest load of TB, and on the list with TB infection and HIV. In 2024, Brazil registered a bit over 84,000 new cases of TB and over 6,000 deaths due to this disease. So, to consider the advances that Brazil has been having in the past decades, it's estimated that 20% of the subdiagnosis happens by improving this technological scenario. And we see that 51% of people with TB did the TRN in 2024, which is an advance compared to 2023. In 2023, we had 48% of people diagnosed with TB had a test, a molecular test done. It's a great challenge that early detection of TB depends on the access to molecular testing, especially in vulnerable populations. And with this, the strategy of adopting the sputum pooling comes up to expand the optimization of lab resources. And this figure is being recognized by all of you when we explain how the grouped or pooled test works. It's a very simple idea. We pool between 2, 3, or 4 samples of people consecutively, and we do an exploration test with sputum. And in a pooling environment, we do the single group. And if the result of the pool is negative, then we based on the fact that everybody is negative, that there isn't a new necessary test. And the results of all of these individuals that provided these samples comparatively are all negative. We have that every consecutive person in a pool of 4 with sputum here, we do the test by X%, and if the result is positive, we need to open the pool, recurring to these samples, and test individually each one of the samples to detect which of them were positive. The main principle for the testing is to reduce the number of cartridges that is used, maintaining the diagnosis objective. Our previous experience, it's not just only what was published. We had data together with colleagues from Nigeria, and it was captained by the people from Nigeria, but we did a similar study in Brazil, and the colleagues in each one of these countries on the pooling test in regards to the test. And in this time, we had an elevated sensitivity and specificity of the technique of compared to the individual samples. As we did this first study in the context of the pandemic of COVID-19, for our surprise, there was an elevated positive samples of lab tests, in cartridges
necessitando,
done
assim,
by
de
an
mais
approximate
estudos
number
sobre
of
a propaganda do PAHO.
13%.
Em
And with
contrapartida,
this
nossos
result
colegas
of
na
more
Nigéria
studies
e
on the
Laos
pooled
observaram
tests,
uma economia de 45 a 50%,
our
então o que
colleagues
também deixou a gente
from
motivado,
Nigeria,
né, a replicar o estudo. E estudo como esse, né,
having
que a
this
gente
percentage
realizou
motivated by the study,
em
did,
Maceió,
did
aqui
a
no
study
Brasil,
similar to this one. There was one that we did here in Brazil,
foi linha de base, né, para o estudo Start for
and
All.
it
É
was
dos braços
based,
do
or it was
estudo
the
Start
basis
for
for
All.
the Stars
Na
for
manhã
All
de hoje,
study.
eu vou apresentar
It
para
was one of
vocês a
the arms of
experiência
the
com a
Start for
sociedade
All study.
aplicada das amostras de descarga
We would
para
like to
diagnóstico de
present
tuberculose
the
no
Brazilian
contexto do Start for All,
experience
do estudo Start
with
for
its
All.
grouped test in a
Nós
context of the
implementamos
Start for All study.
nosso estudo em unidades
We
básicas de
implemented
saúde,
our
unidades
study
de
in
saúde da
basic health
família,
units
que atendiam comunidades
in
de
the
alta prevalência,
communities
perdão, de alta incidência
of
em Aracaju e Maceió.
Aracaju
Nós
that
recrutamos adultos
attended high
com relatos de
incidence
sintomas
communities.
sugestivos de
In Maceió, there
tuberculose.
were adults
Essa triagem
with
estabelecida aos pacientes no ponto de
symptoms
atendimento,
that were similar to
nós
TB. We
integramos
did
nosso
a
grupo de
triage of
trabalho
the
à
patients
rotina
at
do
the
serviço
health
de
center.
saúde
We
e
integrated them to the
total de
health services
309
routines,
participantes
and a
foram
total of
incluídos.
309
Como
patients
estratégia de
were included in
implementação, nós
this
adotamos a coleta de
study.
amostras
As a
local e testagem no
implementation
mesmo
strategy,
dia.
we
A
adopted the
nossa equipe
collection
de
of
campo
local
foi devidamente
samples and
treinada
tests
para
on the same day.
realizar o
The
raio-x
field team was duly
reportátil,
trained to do the
integrado com a
X-rays,
inteligência
the
artificial,
portable
RAG,
X-rays,
um teste
with
de
AI,
resposta reativa através da punção
PCR
digital,
tests,
o teste de urina,
finger
LF-PAN,
prick, the
e para
urine
realizar a
test
coleta de escarro.
is called LFLAM,
Percebam
and
que a gente
for
agora
the
vai
collection of
verificar e
sputum.
apresentar os resultados do
Now
PAHO,
we are
que
going
é
to
proveniente dessa coleta
mention
de
and
escarro.
talk about the results and
Então,
publish the results
os
that come
escarros
from this collection.
coletados, né, lá
So the collected
em
sputum
campo, eles eram enviados à cadeia fria para o laboratório de referência, onde uma equipe
was
devidamente
sent
treinada estava
to a
preparada para
reference
realizar
lab
a
with
testagem
fully trained
individual
team
de forma
prepared
cega,
to
a
do the
testagem em
individual
pool
test in
e
a
também a
blind manner,
cultura sólida no nosso contexto do Brasil.
the pool test, and also the culture in our context in
Ainda como
Brazil.
estratégia de implementação, nós liberamos
Even as a
todos os
strategy,
resultados
the
no
results
dia seguinte. Por
were
conta dessa estratégia
released
de
the
liberar
next day
resultados
or the
em
same day
curto espaço de
as a
tempo, nós
result of the
estabelecemos que no grupo
strategy
2, de
of
3
having
e
the
4
results with the
amostras.
shortest space of time. We had
Também
2,
uma outra
3,
estratégia
or
que
4
foi
samples.
primordial para o sucesso do Start
And
for All,
another strategy
no
that was
contexto
done
brasileiro foi o engajamento
for this study
comunitário
in the
para
Brazilian
reduzir o
context
estigma e
was
aumentar a adesão de
the
rastreamento que a
commitment
gente
of the
está
community to
fazendo.
simulate an increased
Aqui eu trago
adhesion
algumas imagens da nossa
to the
equipe
tracing of the
realizando
study.
atividades de campo nas
Here we
unidades
have some
básicas de
images of
saúde.
our team doing field
Entretanto, nossa
activities
equipe não
in
ficou
the
restrita aos muros das
units and health
unidades de
centers,
saúde
and
da
our
atenção
team
primária. Nós também fomos
didn't
às
restrict to the walls
comunidades,
of
né,
the healthcare units.
onde
We
vinham
also went to
esses
the
casos de
communities
tuberculose, onde viviam
where
pessoas, né, com maior
the
probabilidade de terem
TB cases
tuberculose,
were living, where there
de
were
forma
more people with
integrada
probability
ao
of
trabalho
having
das
TB,
equipes de saúde da família.
as
Então,
a
dessa
way
forma, mostrando
integrated to
nosso
the work that was
trabalho
necessary for
nessas
these types of
comunidades. Para a
communities.
gente conseguir
Showing
esse
here our
efeito, é
work with these
importante dar
communities so that we were able to achieve this
o
effect. This was
engajamento
very
comunitário, né?
important.
Líderes comunitários, eles eram sensibilizados a respeito do estudo
We had
e assim
community leaders
facilitavam
that were
o
used
rastreamento
for the
diário.
study
Como
and thus
resultado principal, nós
facilitating the
temos o seguinte:
tracing.
nessa tabela
And
1,
as a main
nós
result, we
mostramos os
have this.
resultados
In
laboratoriais
this
dos
table
testes,
number
né,
1, we have the
das culturas
results of
individuais e
the lab result of
agrupados
the
das
tests
amostras de escarro que nós
of
testamos. Percebam
the individual and pooled samples.
que
And
quando
you
a
can
gente
see
faz
that
MTB grade, né, quando a gente
when we do
observa
an
a
MT grade,
disposição
we
dos
observe
resultados, é
the
praticamente homogêneo. E
disposition,
nós tivemos 17 pools
and
detectados,
we had 17 pools
tuberculose,
detected,
2 pools como traço e
detecting TB,
57
2
negativos
pools,
para tuberculose.
and
Nas amostras
57 with
individuais,
traces
nós
and
tivemos
57 negative.
27
In the
amostras
individual samples, we had 27 samples
sendo detectadas com tuberculose, 2
that
amostras
were
com traço e
detected with TB,
256
2
pessoas
samples
com resultado
with
negativo.
traces,
Aqui a
and
gente já pode observar que
256
em alguns
negative.
dos pools nós conseguimos
And here we
detectar
can
mais
observe
de
that
uma
in
amostra
some of the pools,
positiva, ou
we were
seja,
able to detect
se um
more than
pool
one
de 4
sample
amostras ele é
in
positivo e nós
percentages. If a
interpretamos que
pool of
pelo menos uma
4,
amostra é positiva,
we interpret
então,
that
e
at
retestamos
least
essas
one sample is
amostras de forma
positive,
individual,
we do a
podemos
retest
encontrar
of these
mais do que
samples
uma amostra
individually,
positiva naquele
and
grupo,
we can
naquele
find
pool.
more than
Se
one
essa
positive sample in that pool.
ele estiver, né, estiver informado. Na tabela 2, eu
If
trago os resultados de
this
concordância
were
entre o
informed
estado
this
do
way.
pool e as
On
amostras
table 2,
individuais.
I bring the
Nós
results
tivemos duas
of
discordâncias, né,
concordance
entre o
between the
resultado
pool
do
and the
pool
individual
e na
samples. We
abertura
have
desse
two
pool
discordances
em
or
comparação
mismatches
com
between
as
the pool
amostras
and the opening of
individuais,
this
onde
new pool in comparison with the individual samples, where one of the pools we identified as positive one of the samples, where one of the samples appeared negative, and in the other pool we identified it as non-detected or negative pool. But when we compared the individual samples, there was a positive sample, which was a trace sample. Our concordance was 97.4%, and a cup of 0.93. It's an almost perfect harmonization between the samples. On table 3, we have the diagnosis of the performance of the diagnosis compared to the culture. We can perceive that when we use an algorithm strategy using the pooling, followed by the expert pool, positive in testing individual samples, we have a superiority in sensitivity, almost like a specificity in comparison to the expert ultra individual, taking as a basis the bacteriological confirmation of the lab. There's always a question, if there is, if there's effectiveness of this strategy, and that's what this table is for. When we look at the average cost per sample of the test, this is a current value of $7.97 on average, and we have this average cost for the individual tests. And when we did the analysis of the cost, considering 76 pools that we have in 64 individuals, we had to do the test again. And our economy was 51. We saved 51%. We had a reduction of work time at the lab that was equivalent to a review of 51.4%. We also faced some challenges on the field. The main challenge, or the initial one, was the initial sensitivity of the lab equipment on pooling, and there was a lack of believing on the performance of dilution, and a savings on the work, and the economy of resources, and the reduction of work. And they thought that doing this pool, this could improve or increase the burden of work. And this challenge was what we see here, and our colleague Anna presented the trace results very well. And this has a low burden, and the result of the pool could be that it may be we're not able to achieve detection. And we could always support the patients what worked well, the integration of the work team with the flow, with the primary healthcare team, instead of creating a parallel system in the associations of the national and local TB programs, and the commitment of the community. And I bring this message that the pooling samples increase the efficiency and reduce the operation costs, and it's an excellent tool for triage in the population, and the expansion for other primary care units. And this is viable provided that there's good training and political support that's necessary. And we want to say thank you to all the colleagues and partners of Start for All that presented here. And I also want to give a special thanks to Dr. Luis Cuevas, leader of this consortium that is so important, Start for All. And he left us in January 2023. I also thank all the partners, institutional partners of Sexercipe, Arbos, Public Health Labs, people from Maceió that work with TB, people that work on coordination of the TB programs, both national and statewide, and all the participants of the study. And we have our contact here.
Gracias, Víctor. Bueno, gracias
Thank
a
you,
Víctor y
Victor,
todos los expositores anteriormente, ¿no?
and to all the previous speakers. There's been very interesting questions
y se han
done,
ido respondiendo en su gran mayoría.
and we've
Quisiéramos en
been
estos
answering
pocos minutos
them
que nos quedan
all, and we'd like in
sacar a
the
discusión
last
algunos de
few
los
minutes
temas
to
que son
bring
importantes, que
a
se han sido
discussion of the
preguntas y se han
topics that
respondido,
are
pero pensamos
important,
que
and
pueden ser
we've
objeto de
answered
discusión y de
many
interés para
questions
todos
that
los
can be,
participantes.
we think they
Una
can
pregunta
be
que siempre nos
for discussion for each participant.
y que
And
respondió
one of the
Patricia y
questions that
respondimos
always
nosotros
comes up,
también,
and
es con relación
Patricia
a la
answered and
conservación de
we
las
answered
muestras.
as
Es decir,
well,
una vez que se toma
is
el
the
hisopado,
conservation of the
en
samples.
este
Once
caso
we
de
take the
lengua,
swab, in
y
this
no
case
es
a tongue swab,
inmediatamente procesada la
and
muestra,
it's
en
not,
este
the
caso por el
sample is not
medidor,
immediately processed,
si existe algún medio de transporte
is
o
there a
tiempo
means
debe
for
conservarse la
transportation, or
muestra y
how
a qué
long should the
temperatura.
sample be
No
kept, and
sé,
at what
Patricia, si
temperature? I don't know,
quisieras
Patricia, if you would
ahondar sobre este
like
tema para que sea
to
de amplio
delve
conocimiento.
into this.
Sure. Thank you so much, Ernesto. I'm happy to answer the question. For the swabs, for tongue swabs, they should be transported dry, and this should be good news for TB programs because it reduces the risk of spill and of biosafety concerns for liquid samples that would be transported from a collection site to a testing site before the sample had been inactivated. Those dry swabs can be held for 24 hours just at room temperature, presuming that the room temperature doesn't go to extreme temperatures. In some settings, room temperature might be above 30 or 40 degrees, in which cases it would be best to test it more quickly. Company guidance is to test it as soon as you can. However, for sites that have refrigeration and freezer options, the swabs can be refrigerated for up to 5 days at 2 to 8 degrees Celsius and at negative 20 degrees Celsius for up to 6 months.
Ok, gracias, Patricia. Otra
Thank you,
pregunta
Patricia.
que
Another
nos han hecho,
question
quizás
that
Patricia también podría
been
responder,
that has been asked, and
cuándo se
maybe
van a publicar
Patricia could answer,
los
is
nuevos lineamientos
when
y
the
las
new
nuevas
guidelines are
manual
going to be
operativo
published
con estas
in the
recomendaciones. Sabemos que
operative
a finales de
manual with these
febrero
recommendations.
se han
And we know
publicado, ¿no?, las
that at the end of
comunicaciones rápidas sobre
February,
estas
we
recomendaciones,
have
pero
the
bueno,
draft
las guías
recommendations
consolidadas y el manual
were
operativo nos
published,
han traído
but
información
the
como son
consolidated
la
guidelines and operative
implementación y otros datos,
guideline
¿no,
were also
Patricia?
published. Patricia?
Sure, thank you. We're pleased that there is enthusiasm and that everyone is awaiting the guidelines and the operational handbook. And I'd like to acknowledge also that we had a representative from the National Program of Brazil and the Guideline Development Group panel to help advise us on the development of these recommendations. Right now, both the guidelines and the operational handbook are processing through editing and design. And so we are working our way towards publication, and we hope to have them published as soon as we can.
Gracias.
Thank
Sí,
you.
queríamos también otra pregunta que nos
There was
salió
also another
es
question that
si
came
está
up,
incluido ya en el Fondo Estratégico de la
if it's
OPS
already
para que
included
los países
in
puedan
the PAHO
adquirir
Strategic
en
Fund for
este
the
caso el mini DOT.
countries to be
Les
able to
podemos
acquire
responder
the
que
mini
sí,
dot.
que ya
And
hemos
we
hecho la
can answer that
recomendación al Fondo
yes, we've done
Estratégico
the recommendation
y
to the
están a
Strategic
estos
Fund,
disponibles a estos
and
precios que
they're
hemos mencionado
available at the
anteriormente, que
prices
son
that
los
we have
mismos que
mentioned
aparecen
before, which
en el
are the same
catálogo del
ones
GDF
that
y del
appear
Global
in the
Growth Facility,
GDF
¿no? Otro tema
catalog.
que también, otra
Another
pregunta que ha
topic or
sido
another
ampliamente
question that has also
también
been
respondida, ¿no?
broadly
Es sobre
answered
todo
already
sobre
is
la utilidad
the
de poder
use
realizar
of being
el
able to
pooling,
do
el
the
agrupamiento de muestras,
pooling
sobre
of
todo en
samples,
condiciones
especially
para privados de
in
libertad.
conditions for
Sabemos que es un
people
grupo de
who
riesgo
are
que se están
incarcerated.
realizando,
We know that
estamos
it's a risk
recomendando en
group.
OPS
We
realizar
know that we're
búsquedas
recommending
activas,
in
sobre
PAHO
todo
to
con la
do
utilización
active
también
searches,
de la
especially
radiología con
with the
inteligencia
use
artificial.
of
¿Qué nos puedes,
radiology with
Patricia,
artificial
recomendar
intelligence.
con relación a
Patricia,
la
what can you
utilización del
recommend
pooling
about the
en
use
situaciones
of pooling
en
in
prisiones, en
people
privados
who
de
are
libertad?
imprisoned?
Thank you again for this question, and there's been good discussion I see in the question and answer section on this topic. So currently, the recommendation that WHO has just issued for the pooling strategy is for settings under resource constraint, and it does not apply to those at increased risk of tuberculosis, including drug-resistant tuberculosis. So, for example, pooling of samples from individuals living with HIV, children, those at increased risk of drug resistance are specifically excluded. However, it was acknowledged by our guideline development group that other countries that have risk groups and individuals that may be at increased risk, such as prisoners, may also be excluded from the strategy so that they receive their own individual tests. And this is really to consider the impact of potential transmission of the airborne disease in this setting. However, we are also aware that there is some evidence that is being generated specifically on pooling in a prison setting. And so this is something that we will watch to see whether or not there may be adjustments in the future. But at this time, we don't have any specifics around prisoners for pooling.
No se escucha,
Ernesto, no te puedo.
Bueno, agradecer a Patricia por la
Okay,
respuesta.
I want to thank Patricia for your answer, and we're saying that it's important or necessary to have this recommendation because as we're doing active searches, especially on those who are incarcerated, as I was mentioning with AI radiology, it's very useful to be able to use the strategy provided that the risk, of course, of multi-drug resistance based on the environment and the country and the positive results that are obtained. We know that pooling is not recommended for positive results over 24% because the yield is reduced because of the later posterior testing. So if you want to expand on this question, you may.
No, Ernesto, yo creo que ya
No, Ernesto, I think that it has been answered already. So we had answered with the quality of the samples. Then when we're going to do the pooling, the samples don't have enough quality, and this is something that could have influence on the results. So I think that it should be better if Ana or Victor can answer to this question and based on their experience in the lab and on the field. Also, can you repeat the question? Like on the quality of the samples, in the case of saliva, if they don't have a quality or amount of sample, there can be an influence on the results. There can be samples with traces or results that are very low, that if they can influence on the results, when the individual samples are going to be repeated. In our experience, we haven't had more cases that are invalid doing the group test than in the individual testing. Meaning if there's a sample that is invalid, an individual sample, even in the pooled samples, maybe it could be better because what's causing the invalidity is diluted. If there's any type of factor that inhibits the amplification of DNA. Yes. And Tom was saying also that in these cases, be the definitive results would be what is obtained when the individual tests or the individual samples are done for each one. And if it's possible to gather a sample with greater quality, it would be the definitive diagnosis, the result of the individual test. The other thing that was interesting to us was the question on what you answered on the use or the combination of pooling of samples jointly with the strategy of the radiology using artificial intelligence software. Yes, on my part, I think it's a key question, and we are doing, right, in phase 2, a study that I think will be responding or findings on results on
yo
this topic,
espero
and
que la combinación
I hope that the combination
de ambos CAT y
of both CAT
agrupamiento
and
por,
the pooling,
por la tasa de CAT sería una buena idea,
because of the CAT rate, it would be a good idea,
tenemos,
but
la
we
evidencia
still don't
fuerte
have strong evidence
este punto. Pero vamos a
on
publicar
this
en este
point.
año,
But we are
espero,
going to
estos
be
resultados.
publishing
Gracias,
this
Pastor.
year, these results, I hope.
Bueno, yo creo que
Thank you
estos
for
han
the
sido los
questions.
temas
Okay, I
principales.
think these have been the
Agradecer
main
nuevamente a
topics.
ustedes
I want
por
to
sus
thank you
brillantes,
once
excelentes
again for your
presentaciones.
brilliant and
Hemos
excellent
tenido más de
presentations. We've
420
had over
participantes de
420
la región.
participants
Yo creo
in
que ha
the
sido un
region,
tema muy
and I think
interesante,
it's been a very
muy
interesting
actual.
topic and
Y
very
como decía
current.
Pedro, pensamos que
And as Pedro
podríamos
was
seguir
saying, we
teniendo
think
una
we
serie de
can
webinars en la
keep
medida
having a
que se
series of
vayan
webinars
publicando incluso
as the new
guías consolidadas.
guidelines,
Paso la
consolidated
palabra a Pedro
guidelines are
para que
published.
entonces haga
I'm going to
el
send
cierre ya.
to hand the floor to Pedro
webinar. Adelante,
to
Pedro.
close the webinar. Pedro, the floor is yours.
Muchísimas gracias,
Thank you so much,
Ernesto. Bueno,
Ernesto.
agradecerle a todos los
I want
participantes,
to
más de
thank all
400
the
personas
participants, over 400
conectadas el día
people
de hoy, a los
connected
colegas, a los
today,
traductores
and the
y por
colleagues, the
supuesto a
translators,
los
and
panelistas.
of course
Muchísimas
the
gracias,
panelists.
Patricia,
Thank you so
a
much,
Mariam,
Patricia,
a Tom, a Ana
Miriam,
Isabel
Tom, Anna,
y a Víctor, y por
and
supuesto a
Victor,
Ernesto y al
and
equipo
of
aquí
course Ernesto and
en
the team
OPS.
here at
Gracias de
PAHO.
verdad por
Thank you
compartir
so
toda la
much for
experiencia que
sharing
tienen.
all the experience
Vamos
that you
a
have.
poner a
We are
disposición
going to make
todos los
available
materiales que se han compartido
all the
hoy, y
materials
la
that have been
grabación
shared
del
today,
vídeo va a estar
and the
disponible en la
recordings
página
of the
web
video will
de
be
OPS,
available at the
y
PAHO
trataremos de
webpage, and
compartir
we will
esos
try to
enlaces
share
y
these
demás vídeos y
links and
materiales
the rest of the
que nos
videos
han
and
estado
materials
presentando.
that
Nosotros
you've been
de verdad
presenting today.
pensamos que es de mucha
We
utilidad para
truly
la
think that
región,
it's
y ya lo
very
decíamos
useful
al
for the
inicio.
region,
Hay que
and we were
trabajar
saying at
fuerte
the
ahora para
beginning
poder
that
hacer realidad la
we have to work
implementación de
very
todas
hard
estas
to make the implementation of all
innovaciones,
of
y
these
también, como
innovations a
decíamos
reality.
antes,
And also, as we were saying
vamos a
before,
seguir
we are going to
desempaquetando y, bueno, comentando
unpacking
más a
and
detalle las
commenting more in
recomendaciones
detail
nuevas de
new
diagnóstico. O sea que
recommendations
vamos
for
a seguir
diagnosis, meaning
con
we're going to
webinars para poder
keep
seguir
going with the
presentando y
webinars to be able to
discutiendo
keep
estas
presenting and
recomendaciones. Les estaremos
discussing
contactando
these
y enviando más
recommendations. We will be
información
contacting you,
para ello, y
sending you more
esperamos
information
poder
for
seguir
this,
contando con la
and we hope to
participación
be able
también
to keep
de
having
los
the
colegas. Con
participation of
esto
our
vamos a
colleagues.
cerrar,
So with
estamos un
this,
poco
we
pasados de
close.
tiempo.
We are a
Agradecerles de
bit
verdad a
over
todos
time. I
por su
really want to thank you all
participación.
for your
Que tengan un
participation.
excelente día.
Have
Muchísimas
an
gracias.
excellent day. Thank you so much.